konferansının ikinci günündeyiz. Bugünün bu salondaki ikinci oturumu. Çok kıymetli konuşmacılarımız var bugün oturumumuzda. Charles Alesi, HIMSS Chief Clinical Officer pozisyonunda yaklaşık 25 yıllık bir İngiltere Sağlık Bakanlığı tecrübesi var. Birçok kuruma aynı zamanda da İngiltere Sağlık Bakanlığı'na da yine danışmanlık yapıyor. NHS olarak geçiyor İngiltere Sağlık Bakanlığı diye belki yanlış ifade etmiş olabilirim ama aynı zamanda da global olarak birçok yerde bulunması sebebiyle bugün bize sunumlarını yaparken daha çok İngiltere bazlı olmasa bile bizim dışımızdaki bölgelerdeki sağlık sisteminde dijitalleşmedeki yol haritaları ile ilgili bilgi verecek kendisi. İkinci konuşmacımız da Abu Dhabi'den, Abu Dhabi Health Service organizasyonunun CEO'su Atif Albaraki. Atif Albaraki aynı zamanda HIMSS Future 50 olarak da seçilen Healthcare IT Leader kategorisinde Future 50 içerisine giren bir yöneticimiz. Bugün ondan da yine Abu Dhabi ile ilgili gelişmeleri, durumları dinleyeceğiz. Ve sonrasında da bir round table diyelim, bir yuvarlak masa toplantısı gibi, her ne kadar masamız olmasa da bir tartışma ortamı yaratmaya çalışacağız. Hepinize geldiğiniz için teşekkür ediyorum. Şimdi öncelikle Charles Alesi'yi davet etmek istiyorum. Yeah, please, Charles, would you like to come here and start your presentation? Thank you.
Thank you. Thank you very much for the invitation. I'm delighted to be here. And really what I hope to be able to do over the next few minutes is really talk a little bit about how healthcare really set the stage more than anything else. I can do this with or without slides, but it seems as though the clicker isn't working. Oh, what have I done? Okay, so we've seen enormous changes in the way that data is being used associated with the pandemic. I don't need to describe that. We're all very aware of it. But clearly we now have a situation where digital modalities are what people talk about, and digital modalities are now the mainstream, not the exception. In the past, they used to be the exception, the pilot. Now they are the mainstream. We're also moving towards a more value-based system, and this is happening all over the world, in every country in the world. And we're also, of course, now realizing the importance of pandemic surveillance, because what this pandemic has shown is the woeful unpreparedness of governments, of health systems all over the world. I'm not saying in Turkey, I'm saying everywhere. Certainly in Europe, certainly in the United States, certainly in Asia Pacific as well, because of course we did not have the systems to enable all that syndromic and surveillance activity which takes place in a country to be displayed real time, to be available. Ooh, that's interesting. To be available to the decision makers and policy makers, because they have to make the decision as to what to do next, and clearly had really very little idea as to what they could be doing. We started to talk about this yesterday, the importance of managing non-communicable diseases, cardiometabolic diseases, on a life course basis, and clearly to do that, you really need a lot of data. And in many respects, data has become the new oil, as they say in the Middle East. But I suggest that it really should be the new soil, because oil you only use once. But data, with every time you use it, it becomes richer. And it really is the new soil because it becomes more and more fertile, more and more full of data points, which is really what we need. And these are the big ticket items. These are the things which are really very hot at the moment. Of course, interoperability, so one's able to actually use data appropriately. With that comes cybersecurity. And of course, you need a place where the data sits, whether that's virtually or in practice. And that's really health information exchanges, which are really the flavor of the month. These things are happening all over the world. They're not only happening in Turkey. They're not only happening in the Middle East, they're happening everywhere. Because if you really want to devise systems to assist an individual in their journey, certainly in non-communicable diseases, you need data which comes from a whole variety of sources. And you need that to be real time, and you need to be able to deploy those data points to develop everything from the artificial intelligence you want to use, but also the best customized care for somebody, and there's no other way to do it. And also, how can you do the research that you need to do, other than you have that connection? And also, of course, how can you start to get a glimpse of what the outcomes are, unless you have a system whereby you can interrogate the different aspects of care of an individual to be able to get a view as to how good your health and care system really is. So, as I said, Singapore, Taiwan, Japan, they're all at different stages in developing these systems. But clearly, the direction of travel is identical in all of them. Similarly, of course, in the Middle East, and we have a presentation from Abu Dhabi, which in many respects is the most advanced in the way it's thinking around the management of data in a health information exchange. And then in Europe, we have some pretty good examples, because of course we have the Scandinavian countries and also the United Kingdom, because of the National Health Service has a single spine, so theoretically it should be possible to do this. The practice, of course, is a little bit more difficult. And finally, the real issues are the issues which I think we should be aware of at the moment. Barriers around data privacy, and I don't think those are necessarily something bad. They're there to protect the citizen. But their deployment is actually quite a big issue, how you actually use those. The secondary use of data, in other words, using data for the purposes that it wasn't collected originally. There are various initiatives, some in Scandinavia, some in other countries, around the management of secondary use of data. This is a very hot topic, and one which often gets governments in conflict with its population, mainly associated with trust or lack of it around how good an organization is at actually managing the security of the data, because of course that's really the important thing. And the other barrier, of course, are commercial considerations, because you could have two hospital groups in competition with each other, suddenly exposing themselves. Everybody can see how good they are, and that in itself is a challenge, of course. So that's really all I wanted to say. I just wanted to set a scene and give the stage to somebody who has done it rather than has talked about it.
Thank you, Charles. We're going to get together again after the speech. Now, I want to introduce you Atif Al-Baraki. He is the Chief Executive Officer of Abu Dhabi Healthcare and Malafi, and he is the recently elected for the Future 50 in the HIMSS, in the Healthcare IT Leader. I congratulate him for this achievement as well, and I'm happy to see him here in Turkey. Yes, please, Atif, would you like to give your presentation?
Hi, assalamu alaikum, and good morning, everyone. And thanks, Kurhan, for the introduction. Thanks, Charles, for the presentation. So I'll be walking you today around the journey that we have taken in Abu Dhabi for building the Health Information Exchange, or what's known as Malafi, which in Arabic is My Medical Record. And just a quick background, while we put the presentation. Abu Dhabi is a city in United Arab Emirates. United Arab Emirates is a country of federation of 7 emirates. Abu Dhabi being a capital, it's around, the total country population is around 10 million. In Abu Dhabi, we have around 3.2 million people living in the emirate. And while we put the presentation, the healthcare system in Abu Dhabi went through a major reform around 15 years ago. It was a single-payer system where the government, it was a welfare system where the government was providing the services. And there was an aspiration of moving into an insurance-based healthcare with universal participation, universal insurance coverage, and to promote the private sector to play a bigger role in providing care. And in the last 10 years, that have really elevated the quality of care in Abu Dhabi. It made a lot of big private healthcare providers to come and start providing care in Abu Dhabi. So the likes of Mediclinic, Cleveland Clinic Abu Dhabi, Mayo Clinic also recently, they established a partnership as a JV with the government. And that gave the population access to various private sector facilities in Abu Dhabi. That also improved the quality of care, and it really created a healthy competition between the healthcare providers in promoting and improving their services that they are providing to the population of Abu Dhabi. But it also created a lot of fragmentation in healthcare. So while the state-owned facilities in Abu Dhabi, so we're talking about 13 hospitals and 60 clinics and centers, were all connected through one electronic medical record system from Cerner, there was a lot of other private hospitals. So the number of hospitals in Abu Dhabi is around 60. 13 are owned by the government, but the remaining are private. And everyone is using their own electronic medical record system, let alone the other medical centers, the clinics, the pharmacies. There was no integration between those facilities. And it was the same patient who was using the insurance, and they were able to move, between different facilities. So the government, started to come with an idea of we need to build a health information exchange, a platform that will connect all the healthcare facilities in Abu Dhabi so that the patient, regardless of where they move in the continuum of care, their medical record should always be available through a central clinical data repository, and to provide the physicians or the clinician easy access to the unified medical record of the patient through a click of the button in their electronic medical record system. So that was the high-level idea of Malafi. In addition to that, the government wanted to get various insights for public health and population health programs. And really, during the pandemic, we have seen the value and the power of having such a platform where we're able to monitor the spread of the disease, look at, when at the early days when the government decided to maximize the number of PCR tests that were happening in the Emirate, to really monitor the positive cases, are they being followed up, and the recovery rate and the spread of the disease. And then at a later stage, when we started also the vaccination program, there were various centers in the government and in the private sector where people had to get access to go and to get vaccinated. But through that platform, we were able to integrate and ingest all the data from the different facilities and to give insights and to link it then to the medical record of that patient, to the various PCRs that are happening, so people who are getting vaccinated, but then they get the disease. So to also do some analysis in terms of the effectiveness and comparable between different vaccination options that were available in the Emirates. So that really showed the value for public health use cases. And currently we're working with the government to look at various population health insights, doing descriptive analysis to know the existence of certain diseases in the community, working also on predictive models on 7 specific conditions to see people who are at high risk in the next 12 months of getting specific medical conditions based on 2 years of historical data that we have for their conditions, and also in working on additional use cases on using AI and machine learning based on the data that we have. I just want to check if the presentation is going to be put over here so that I can go through the slides. So while they put the presentation, maybe I can start covering in terms of how did this journey all started. So in 2018, we started working on a business case. So the problem that we were facing, that okay, there was fragmentation in healthcare. We wanted to achieve the central exchange between the different facilities and to give the insights to the government. So we started looking at how can we achieve this. And we looked at 3 angles. We started looking at the business model. What's the best way of ensuring that we can build a self-sustained platform? So who are going to be benefiting from this? Looking at the providers, the payers, the patient, and to put a financial sustainable system. So you can build a system, but to ensure that it gets self-funded in the future. You look at various stakeholders, and we gave various options to the government that through policy and through mandate, they looked at promoting a way so that it's going to be self-sustained through a per member per month fee that's going to be funded by the insurance. And then we looked at the technology model. So how can we build an HIE? And we have benchmarked and looked at various countries who have built an HIE. And there are various ways of doing it. Should it be a central system? Should it be a federated system? And all those were driven by the use cases and the ultimate outcome that we wanted to achieve. So analytics and insights was one of the key requirements. So we decided to go with a central clinical data repository architecture, where we pull the data all into one central clinical data repository, and then we give easy access to the electronic medical record systems to access to that unified medical record of the people. The third aspect was on the operating model. What's the best way of operating an HIE? Should we just build a separate department within the Department of Health, or whether we should establish a separate company that's going to be responsible for running and operating the HIE? And the operating model that we have decided is that we established a company, which is Abu Dhabi Health Data Services, that is responsible for building and for operating the HIE. And this company, at the end, was done as a public-private partnership between the government and a private company called Injazat Data Systems, where the company invested in building the platform in a build, operate, transfer model. We're currently operating the company, and it was a 10 years concession period with the government. We have already completed 3 years, and at the end of the concession period, the company, as Abu Dhabi Health Data Services, is going to be transferred back to the government, and it's going to be self-sustained as an organization to continue operating the health information exchange. That was decided as the operating model. We then launched the program in January 2019. And one of the key lessons learned that we have learned in the last 2 years is that when you launch such a program, it's very, very important to put a sense of urgency. We went initially with a plan of having 7 years to build and then to roll out the system across all the healthcare facilities. We're talking around 2,000 facilities in Abu Dhabi. And one of the key aspects that we got from the chairman of the Department of Health is that there needs to be an accelerated approach and to provide that sense of urgency to all the healthcare providers in terms of connecting to the platform as soon as possible. So we had to crash the program. The regulator had to put specific mandates and timelines for people to connect. And if people do not connect, there must be a consequence in terms of ensuring that there is an enforcement mechanism to ensure that people connect to the platform. No, it's the other presentation. So in 2019, we focused first on building the platform. The first 6 months was focused on building the platform and getting the first 6 healthcare providers connected. But then 2019 and 20, the focus was on accelerating the onboarding. So we had to ramp up the teams that were there and also to provide a clear mandate to all the healthcare providers that they need to connect as soon as possible to the platform. When the pandemic hit, it was also another key challenge in 2020, where for the healthcare providers, they had various competing priorities. They had supply, they had staffing that they had to ramp up. They had various operational challenges to combat and to fight COVID. At the same time, there was still that sense of urgency was kept by the regulator, saying that, yes, we do have COVID, and we had to prioritize connecting the labs and the centers that were doing PCR tests and people who started doing the vaccination program. But at the same time, we did not drop the mandate of having a platform connected and every single facility to connect to the platform. So we continued in also accelerating the onboarding program. And as of today, we have covered a good percentage of the population, of the facilities in Abu Dhabi, which I'm going to cover in the coming few slides. I have already covered. I'm just going to go back to certain things that I've discussed before. I've already covered the, Abu Dhabi and the population in the Emirate. This just gives you a view about the journey that I have highlighted. That in 2006, there was a change, or there was a major reform where we had, mandatory insurance, and that created the fragmentation, which Malafi was trying to tackle by building a health information exchange that connects all the electronic medical record systems. And the simple idea is to have a platform which is connecting all the hospitals, medical centers, clinics, and pharmacies, and giving the government, insights for population and public health use cases. Insurance were contributing in terms of sending claims data to the platform, but they don't have access to the medical record. And for the patients at the end to get easy access to their unified medical record across all the facilities that they visit in Abu Dhabi. The simple idea is that we connect with various electronic medical record systems, lab information systems, pharmacy management systems. So regardless of where the patient moves in the continuum of care, if the patient moves from a GP to a specialty hospital to a home care facility, and in between in a lab and pharmacy, all the data gets pushed to Malafi, and then we provide easy access to the physicians and the clinicians through their electronic medical record system. The key building blocks of the platform is that we have a real-time data exchange platform from Rhapsody, and then we have a patient matching solution from NextGate that, based on the data that we receive, it matches the patient records. And then we store the data into our Amadeus platform from Orion into a clinical data repository. And then using various analytics and BI solutions, we can push the data to a different repository, and then we can apply BI solutions from various vendors to get specific insights that we then present to the clinicians through what we call provider portal, which is embedded within their electronic medical record systems. And that was one of the key decisions that we have taken, is that we said that the physicians should not go and access another portal. It should be embedded within the EMR system that they are using. And that was a key decision to ensure that people adopt and use the system. But then we have a different insights portal where specific users with specific permission can go and look at aggregated data and get various insights from the data that we have. As of today, we have 100% of the hospitals in Abu Dhabi. 59 hospitals are already connected. We have 94% of the clinics and centers connected, 60% of the pharmacies. And that gives us a market episode or a patient episodes that are happening. 99% of the episodes that are happening in Abu Dhabi are already coming to Malafi. We are targeting to connect 1,950 facilities. We have already connected around 1,600. The ones that are still remaining are the small pharmacies and some of the small clinics, which don't have a mature system yet. So we're helping them in terms of either changing their system or getting their system to be interoperable and to meet our Malafi requirements so that they can connect. And what really helped to accelerate that onboarding was really the mandate that the government have taken in the last 6 months, where they issued a circular saying that if someone is not connected to Malafi, any facility that's not connected to Malafi, they will be outside the government-funded insuring program. And that really accelerated the onboarding from those providers that were still not connected and ensured that we achieved this in the last few months. Number of users, around 40,000 users who are already having access to Malafi. And for a platform like this, the value of the platform increases as we connect more facilities. So in the early days, we focused on building the platform and ingesting the initial data set from key providers, but then we worked on integrating the market and connecting more providers. And as we connect more providers, we get more value from the system. And at the same time, when we reached a specific mass of users, we started working on an adoption program where we have a clinician team, a clinical informatics team within the organization who is working with different healthcare providers to use the system and to see and to realize the value of the system. And at the top there, you'll see that we also, especially during the pandemic, we started working on different analytics and insights to get insights mainly around the COVID-19 situation, but also on building various insights for the public health and population health programs. The ultimate goal of what we're trying to achieve with Madafi in Abu Dhabi is really to improve the quality of care and help to contain or even reduce the cost of care and the expenditure that's happening in the Emirate. And the journey that we have started and we're taking is, first, we focus on building the HIE and building the foundation of the platform. Second step, we focus on connecting the healthcare providers and empowering their users, the physicians and clinicians, to use the system. Today, based on the analysis that we're seeing, is that 40% of the users are accessing the system at least once a month. And for us, that's a very good adoption rate, because we were not expecting every clinician and physician to access Madafi, but really when there is a need, they need to access Madafi. And that really helps in, you can see the arrow at the side, it helps in care coordination and care management in the Emirate. But we don't want to stop over there. We started building various analytics and insights based on the data that's aggregated, and to help the government in building various population health programs to manage people who have specific chronic conditions. And at the same time, based on the data that we have, to start measuring quality and outcomes. Currently in Abu Dhabi, there is a program called Jawda, which is looking at the quality outcomes of certain indicators, and those are self-reported today by the hospitals. Can you automate certain quality indicators so that based on the data that's available, you can start measuring the outcomes of certain procedures, and based on that, then to focus on changing the payment method so that it's more outcome-based and moving from fees for service to outcome-based payments, and that will push the market then to further improve care coordination, which will eventually improve the quality of care and help in containing and reducing the cost. Key lessons learned from our journey is that self-sustainability and putting a sense of urgency is critical to ensure that such a platform or such initiatives moves fast and you start realizing the value. The other aspect is provider readiness to connect. So putting a team that works very, very closely with the healthcare providers, being it the clinical team or the technical team, to ensure that their systems are ready, their clinical workflows are reviewed very well, and that access to Madafi is done in an easy way. Third aspect is data quality and data maturity. And at the beginning of the program, many people are saying, should Abu Dhabi start in the program, or should we focus on driving standardization of certain data sets? We had reviewed our data maturity at that side, and we felt that based on the mandate of the insurance, we had a good foundation in terms of data standardization of specific data sets. So, for example, diagnoses and procedures were already standardized in ICD and CPT. But then there were certain data quality or data standards that were still having some areas of improvement. So in parallel, we have worked with various stakeholders to start putting various data standardization program and to continue improving the maturity of the data and the standards that are available in the market. One key aspect is to have also another, which is mutual responsibility between participants. So we worked on a data sharing agreement that gives various responsibilities of different participants who join the network, and ensuring that there is obligations between the various participants who are exchanging the data. And the last part is the clinical engagement and having a clinical team within the organization that's working very closely with the different participants. And as Charles highlighted in his presentation, there is a lot of opportunities with the data that's available. The first aspect is to get insights, being it descriptive, so you can monitor the historical trend analysis, and doing descriptive and predictive insights so that you can also predict the future using AI and machine learning. But also at the same time putting a framework where you can have the data available for secondary use, so that you can have it available for research, for academia, but putting a trust framework where you can get the public trust. You can get the trust of the stakeholders who are sharing the data to ensure that the data is securely and while maintaining the privacy of the patient is available for research and for academia. And we're starting to work on such initiatives with the Department of Health to ensure that that's available. And that really then creates more potential with the data that's available. So that will take me to the end of presentation. Thanks for listening for the presentation, and I'm open for any question after the session. Thank you all.
Should we take chairs or Thank you, Atif, for your nice presentation. Who doesn't know too much about Abu Dhabi? We really had good information what's going on in Abu Dhabi and what your plans are as well. I would like to ask some questions to you. First, Charles, you travel a lot and you have no borders for you, and I just want to ask you, what sustainability and interconnectivity, even it's not easy in a hospital. So how is it going to happen in the worldwide? What do you think about this?
Well, I think one of the best use cases I have ever seen, and I've been lucky to be, one of the best use cases I have ever seen, and I've been lucky to be associated with Malafi practically from its inception, as you remember, is this use case, because in many respects, Abu Dhabi had all the advantages and all the disadvantages when it started. As you described, as if it was a situation which originally was a single record, which suddenly there were all these new players involved. But also, you were fortunate or unfortunate enough that you didn't have a system which half worked. You just didn't have a system. So you built it from the ground up. And if there is an example of a system being built on the ground up which works and deployed at speed, not talked about, but deployed at speed, I think it's Malafi. And I certainly talk about this all over the world as the use case, because I think it is the use case par excellence. However, not all countries are in that situation. Some countries have some legacy systems which half work. And there are also some other considerations which I think I highlighted around secondary use of data, cybersecurity, different models, federated systems, and systems like you described, where because of sensitivities of populations, perhaps the Malafi approach won't necessarily work in every part of the world. But if I had to think of the ideal, I don't think you're particularly far away from it.
Thank you. Would you like to say something about it, Atif?
Yeah, I think.
Okay, just talk, but connect you.
Okay, so I think what really helped also is to get that universal participation. So when you have a mandate, and you have really the regulator who can do the enforcement, what's needed, and then you have another entity or partner, which is Malafi team, building on the partnership with the different stakeholders, with the participants, and putting a team that works very closely with the technical team, with the clinical team. But then when needed, you have that enforcement, and to build that partnership, to create, that incentive to connect, and then the enforcement when it's needed. That's very, very critical in such such initiative, and creating that sense of urgency. I remember when we started this program, we were talking about 7 years to connect everyone. Yeah. And the first meeting I had with the chairman of the DOH, he was like, no, this has to finish in 1 year. And that was, negotiation, saying, no, that's not possible to do it in 1 year. Yes, we have now completed 2 years, since we launched the program. We're going to complete 3 years by January next year. But that sense of urgency, that creating that, it has to finish faster, and to put that pressure to the market, that really helped. And some people felt it was unrealistic timelines. Yes, we did not achieve 1 year, but in 3 years, we were able to connect almost 100% of the market.
I have another question about the future plans. I mean, mostly about the patient engagement. So what we are looking for in Turkey as well for the patient engagement, and the HIMSS has some standards for the upcoming 2025 standards for the stage 7 hospitals, and we are really focusing on the patient engagement. Would you like to say something about it, Atif, first of all?
Yeah, so let's say if I talk about it from an HIE organization, we were planning to build a patient portal. 2 years ago, we were thinking, oh, you know what, Malafi should have a patient portal. We put that initiative on hold because we felt, you know, having a portal where people just have access to their medical record was not sufficient. So what we have done is that we created an API layer to enable third-party applications, being it either the healthcare providers, so people who already have today a patient engagement app, you know, to really build on that solution, and for them to allow patients to have access to their unified medical record through integrating with Malafi, or through what we call an Emirate-wide or Abu Dhabi-wide solution. So the government today in Abu Dhabi, or the Department of Health, is looking into building a virtual care platform. So to have it as a digital front door for the people in Abu Dhabi to really get access to various services, being it scheduling an appointment, so pre-visit, and after visit, getting access to their medical record, or let's say getting access to various interactive engagement with the different healthcare providers, and still have the providers also have to continue having their, let's say, point of care engagement solution for different hospitals, but then to have also one digital front door to various services, being it also teleconsultation, scheduling visits, through one single platform that will also be focusing on the health consumerization. So, you know, to give that same experience that patients can get, or people can get by dealing with various, let's say, digital solutions today, through that digital front door. And the challenge, I don't think it's going to be in the front end, let's say, building of that engagement. It's going to be on revamping your back end processes as healthcare providers, you know, to give that experience that patients are already seeing it today in various services outside healthcare.
I would agree. I think this is absolutely essential. If you look at the management of non-communicable disease, you're really looking at a lifelong approach to care. If you're looking at a lifelong approach to care, access to a medical record, but not only access, the ability to write and interact with a medical record is absolutely essential, because that's the only way in which you're going to get people to believe the treatment plans for whatever condition they have are also theirs, because it's customized to the individual. This is a very long journey, and some countries have adopted different approaches. I mean, Finland is particularly interesting because of their MyKanta approach, sort of a governmental approach, which is basically a single clinical record, which is available in its totality to all the population. But they've been working on this for many, many, many, many years. So I think you're going about it the right way. I think this is where the focus is going to be, because if we want to get improved outcomes, you really need to engage people far more. The medical record is actually their medical record. It's not anybody else's.
So it's like personalized medicine, we're going for it?
Absolutely. This is the future. And this is what's happening all over the world, including in Abu Dhabi. You know, you're now able to interrogate the data to look at outcomes in different parts of the Emirate, to look at outcomes from the different providers to improve quality. And that is started. Now, the more people are engaged in this, the more you'll accelerate towards that improvement in quality and outcomes, which at the end of the day is what your Department of Health want. That's why you're there. So I think this is a real virtuous circle. Of course, one has to be careful in terms of cybersecurity. This is the big issue, as always. But, you know, it's something we're just going to have to live with. I know it's difficult.
Thank you. Atif, I would like to ask you what your future plans in your emirate about the telemedicine and telehealth. And are you going for some regulations to the reimbursement of the telemedicine, whatever happens, like the malpractice or something like that?
Yeah, absolutely. I think, you know, the COVID accelerated that adoption. So people were talking about certain regulations and the reimbursement. When COVID hit, I mean, that was the only option that was available. So, you know, a policy was put in place very, very quickly, and reimbursement was agreed very, very fast with the insurance. And that really enabled the providers to provide that access. And people today, in Abu Dhabi already see that it is an option that's available. I know few providers who have already seen certain percentages of their visits are increasing through telehealth and teleconsultation solutions. There are various startups who are really also able to pick up on that demand in the last 18 months or 2 years and really provided services to few healthcare providers. At the Emirate level, the government is already working on this virtual care platform. So to have that digital front door that's going to complement, it's not going to replace the channels that already exist today with the different healthcare providers, but to have also another, let's say, single door access for the Emirate as another channel to get access to the teleconsultation and telehealth visits with the available market. Now, it is still focused on having just teleconsultation within the, let's say, licensed facilities in Abu Dhabi. I think if you're talking about, let's say, consultation cross borders or in other countries, that regulation is still being worked out. I don't think we're ready, neither in Abu Dhabi or also even globally to have that. But I think that's going to be the future aspect of ensuring that people have easy access to care wherever they want it in the world.
To you, Charles, you're a physician as well, so I just want to ask you, can we use the telemedicine in all parts of the medication or the treatment? Just, I want to open my question. There was a program in Europe, MUST project. It was about the chronic pulmonary disease and also the decubitus ulcers, pressure ulcers, and then that was a thought that we could use only in this part of the medication treatment for the telemedicine. What do you think of this?
I think we need to move away from this concept that telemedicine is going to end the interaction between people. The art of healing people, the art of caring for people, and I use the word art rather than science, is one which encompasses a whole host of different parameters. And telemedicine is very useful because it's available, it's very green in terms of cutting out a lot of travels, it has a lot of advantages, but it is particularly difficult to offer compassion, which is part of healing, which is part of what a care system does with an individual. I think we understood quite rapidly that there are limitations to telemedicine. Those limitations are fine, because I think we now have an understanding that what we're moving towards is a very multimodal approach to the consultation, for example. The differences between a transactional relationship and a longitudinal one, the ability to be able to negotiate around risk reduction and behavior change. These are all skills which clinicians learn over years and years and don't transpose very easily to digital media unless there is a change in the way that consultation and that process takes place. So I am at present undertaking a really very significant piece of work looking at understanding the consultation in this new digital world and understanding the relationships of physicians with these new digital modalities in this new digital world. But I think we've moved away from it's either telemedicine or face-to-face to telemedicine, face-to-face, telephone, text as part of a process of engaging people on a regular basis, because that is the basis of care.
Yeah, no, I'll totally agree with Charles. I think it's going to continue being a new channel. It's not going to replace the existing channels, especially the face-to-face or the physical aspect. It's going to be a channel. And the people element is the most difficult one that will have to change. I think the consumer behavior is changing. People are going to be, I'm not going to say asking, but maybe even demanding for that channel to be available, within the healthcare providers. And then for them to have the choice to use it, either to have a visit or to have a tele consultation. So that will create more pressure and demand on the healthcare providers to really look at re-engineering their processes, the way that they engage with the patients. So not just the people element, but also their back office processes, and to make that a smooth transaction or through smooth experience. The technology part is the easiest part, but the people element and the process element, I think, are going to be the most difficult one for the healthcare providers. And I'm expecting there will be more pressure, or let's say consumer demand, that people will be asking for that services to be available as an option, for the patient.
Thank you. I just want to ask to the audience if they have any question to our speakers. Yes, Osama.
A question with regard to the ROI of HI. Do you think that you will have a framework, clear framework, that provides an ROI for HI, for investors, for leadership, more of like tangible?
Yeah. So what we did, Dr. Osama, before starting the program, we did literature review. So we looked at what others have done, and then we quantified it in Abu Dhabi, saying, okay, if this is what, let's say, South Korea have seen or a different state have seen, then this is what we expect in Abu Dhabi. So that was done before the program and at the early stages of the program. And now we're planning to do an analysis to look at the outcomes and the value that it has, a quantifiable outcome and values. And this is going to be a program that we're going to initiate next year. The challenge that we face also in doing that comparison is that COVID created that challenge of we were not able to compare, let's say, how the trend was in 2018 and 19 before having an HIE with 2020 and 2021, because there's that COVID element. But we're planning now to do a framework, and next year to start measuring certain key indicators to look at quality-wise, what are the outcomes that we are seeing, and from cost in terms of overutilization of certain services, are we seeing a change of trend in terms of consumption of certain services, and then to link it to what does that mean from monetary value to the expenditure in the Emirate.
I think maybe one of the good ideas that maybe can help with that is to see what was the contribution of HIE during COVID. So to be easy benchmark to see, like a city that doesn't have HIE at the time of COVID.
Question?
How much they expend already, the expenditure that they expend on developing digital healthcare infrastructure to support COVID.
Yeah.
So this could be a very, very good, easy number to compute and offset and compute it as an ROI of the HI.
So there are some direct indicators. So for example, quality and, let's say, overutilization of services. But then also there are wider economical value. So right, especially during COVID, if you have better insights, then you take the right decision, which then impacts also even the economy in terms of opening up the economy, the life of people going back to work, their productivity, and how that also contributes to the wider economy. So we have done just literature review, but we did not, especially for the economical uplift, it's very, very difficult to quantify it. Yes, there is an opportunity because, but we have done literature review. So to see over the next 20 years, what are we expecting in terms of direct quality and cost and wider economical benefit. And now what we're planning to do is for the direct, let's say in terms of cost and quality, we're trying to quantify it. In terms of economic uplift, it becomes very, very challenging to really quantify that outcome. But based on literature review, we do have numbers, knowing that over the next 20 years, how much would a platform like Malafi contribute to the wider economy of Abu Dhabi?
What about clinical engagement? Have you done any benchmarking around that, comparing with other HIEs in the world?
So in terms of literature review, in terms of, let's say, benchmark of utilization or outcomes? Yani?
Clinical engagement per se. So how they really interact with HIE and how it really affect the final outcomes. Yeah.
So one thing that we try to look at is the adoption rate. So based on the number of users, how many are accessing on monthly basis, and we did an unofficial offline, let's say, comparison with other HIEs. We see a very good trend in terms of adoption, in terms of usage. But when it comes to outcome, we did not do that yet. We're planning to do it next year.
Do we have any other question from the audience? Okay, thank you. So I'm going to end up the session. I don't want you to stay more before the lunch. Thank you for coming here, Dr. Charles Alessi and Atif Al-Baraki. We are so delighted to meet with you and hope to see you next year in HIMSS Eurasia 2022. And thank you for the audience coming up here, and see you for the next year as well.
Thank you.
Thank you, Charles. Yeah. Thanks. Thank you.
Thank you, my friend. I'm going to rush off to the airport. No, I'm going straight. I want to get back all the way to London. There's also critical decisions.
This is you ending fire, and we should all burn together. Watch the flames climb high into the night, calling out Father, stand by and we will watch the flames burn all along the mountainside. And if we should die, we should all die together. Raise a glass of wine for the last time. Golden out, Father, prepare as we will watch the flames burn all along the mountainside. Desolation comes upon the sky. Now I see